He ururiti he nako kātou hāwhakatau ko rangi nui e tui honei kātou hāwhakatau ko papatuanuku e tā ko toa ke nei. Kātou hāwhakatau ko te mātuku mai urarotonga. Kui aruku hia manua pau roto, kui aruku hia manua pau aho. Kia tina, whakatina. Te more I hoa I ki e pupu ana hoki, e wāwau ana hoki. Tā rewa tū ki te rangi, e ke pānuku, e ke tangaroa. Taumai te Māori, aumi e ui e, tāi ki e. E ngā mana I ngā reo, ngā karangaranga maha o te motu, nau mai, hare mai, whakatau mai, ki te whare wānanga o tākau ki pōniki. Nau mai, haria mai o koutou tini mate, kua whiturangi te rātau, haere, haere, haere. Haere ki te pai roa matariki me rehua, ki te toe o ngā rangi ki ngā rangi tua ngāhuru ki ai o matua. Rātau rā, ei mātakitaki mai ki a tātou, ngā kanohi ora, ngā pukenga, ngā ahorangi, ngā tākuta. I hui mai nei mo tēnei ahi, mo tēnei ata. Koto rā, he mihi whakahono re tēnei, ki o tātou nei manuhiri tuarangi, no tā wāhi, no te iwi take, o Navajo, ki a koe e Patricia, nau mai, hara mai, whakatau mai. Ki tō o tupuna no Amerika, me tō hōrangatira nei I whiri ai o korua pūkenga kōrero, I nanahi rā, I tēnei rā, e ngā wā katoa, nā mātou nei o te iwi Māori, hei mihi atu ki a kōrua, hei tautoko ki o kōrua huarahi mō tātou katoa, mō ngā iwi Māori, mō ngā iwi Pākehā rānei. Ka tira, nei rā te mihi atu ki a kōrua, ki o koto katoa, no ngā hau e whā, ki e tahi o tātou manuhiri anō, ki te kotuku rerenga tahi ki a koe e te rangatira, he whanaunga no a Navajo, tēnā no hoki koe, kia ora. Huri noa, ki te iwi te mana whenua no konei, ko Taranaki whānui, ko Ngāti Toa rangatira, kei te mihi atu tēnei, ki ngā whānau o Oratoa, I haere mai ki te tautoko. O reira, tēnā kōrua, tēnā kūta katoa. Huri noa, he whakapōpoto tēnei wā, nā te mea, anei o tātou nei whitu, mo tēnei rā, ki te whakawhiti kōrero e pāne ki te kaupapa o te rānei. Nō reira, tēnā koutou. Hei tīmata tēnei wahanga mā te karakia, katira karakia mā tātou. Whakataka te hau ki te uru, whakataka te hau ki te tōnga. Kia mākina ki uta, kia mā taratara ki tai. E hiaki ana te atakura, he tio, he huka, he hauhu, tihe Māori ora. Kia tau te rangi Māori e, kia hauho te rongo, kia kotahi ai tātou katoa, ai ake nei ai. Nō reira, kia ora tātou. Ladies and gentlemen, just a brief welcome to you all, to your dead that have passed on, to those that we have lost in this year, that have gone to sit upon the platform of Matariki and Rehua, to sit beneath the gaze of our Creator, who gaze upon us and our works that we do here today. We acknowledge the arrival of our distinguished guests, Patricia Henderson, and also of her husband from the nation of Navajo and the nation of Lakota. And to all of you from the four corners of Aotearoa, whichever iwi you may descend from, be it Scottish, Irish, Japanese, French, Māori, Pākehā, nau mai, hara mai, whakatau mai. In all of this, great acknowledgements are also to our mana whenua, who provide us with a process and a kawa to proceed forward. So without further ado, acknowledgements to my iwi, the Ngāti Toa Rangatira and Te Atiawa, and to all of the iwi who are here today. Nō reira, kia koutou katoa, tēnā koutou, kia ora mai tātou. Kia ora. Kia ora mai.
Tēnā koutou katoa, ko Richard Edwards aho. It's my great pleasure to welcome everyone here and also who's online with the webcast to this Aspire 2025 seminar today. This is, I just acknowledge, this is part of work, or fits in with work that's been going on with Indigenous tobacco control, which Anru Wā has been very instrumental in leadership of, and he's been behind the organisation of today's event. So it's my pleasure to introduce Dr. Patricia Henderson. So Dr. Henderson is a member of the Diné Navajo tribe. She's Vice President of the Black Hills Center for American Indian Health in Rapid City in South Dakota. She earned her Doctor of Medicine and Master of Public Health degree from Yale University, and she's one of the foremost experts in indigenous tobacco control from North America. And her work has led to the Navajo Nation passing commercial tobacco-free policies for government workplaces and ceremonial settings, and increasing excise taxes on tobacco products. So she's been very important as part of the tobacco control within the Navajo Nation. And she's going to talk today about the title is Engaging American Indian Communities in Tobacco Control Research and Potential Relevance for Māori People. And I think we can all learn a lot from each other's experiences in tobacco control, and in particular in indigenous tobacco control. And so it's wonderful to have Patricia here. She's also recently just come from the Oceania conference in Hobart in Tasmania, where she gave an excellent plenary address, and just to acknowledge that Harpai was instrumental in organising her attendance there. So welcome, Patricia, and we're really looking forward to what you've got to say.
Yat a bene, Shea Patricia Nez Henderson in Shea, an inchlant, what's on the Bashish chain, Chenjikin a dashanal, Ashche dashache, but a sando amado as a itinenshle. Good morning, everyone. It's a pleasure to be here this morning, and I just want to thank the Anru who invited me to come out and and taking care of us while we've been here. We've truly enjoyed our time visiting your beautiful country. I come from Navajo Nation, which is high desert, so we don't have any big bodies of water. So just to have the ocean nearby and to see the, everything that it's created through the animals and the landscapes, it's just been really, really wonderful. So thank you. Thank you for coming today, and for those that are listening online, thank you for being there. Today I'm going to talk about something that started probably about 10, 15 years ago. But before I jump in there, let me see if I can get this thing moving. It's a project that was very close to my heart, and like many tobacco advocates in this room, you're not in this work for just the fun of it. You're very, very passionate about it. And so this work came out of there. But the main objective is for you to better understand just the work that is required in Native communities in terms of research, and hopefully that, some of the information I will share with you, you can use it in your communities. In 1999, a report was done by NIH and found that out of the 30,000 principal investigators, that less than 10 of them, specifically 9, were American Indian or Alaska Native descent. But over the last 17, 18 years or so, the numbers have increased to now 100 Native PIs. And this is really, really important because it really talks about the need for career development for those that work with Indigenous populations. And I've been very, very fortunate to be involved in a 2-year program that was started by two of our mentors, my husband and I's mentors, and now colleagues, who've really done a wonderful job and just basically providing us with training so that we can do the work that is needed in our Native population. As a Navajo woman, a Diné woman, my philosophy is always based on the balance, what we know as Wajon. And my work is that. Like, we know that many products, including tobacco, commercial tobacco that is, really harms that balance. And I'm sure the philosophy is probably similar among the Māori community. There are certain things, particularly tobacco products, that really harm that balance. So I went in from a Navajo perspective into a different community. My husband's Lakota Sioux from the Cheyenne River Sioux tribe, so basically went in as a visitor. And it's a patrilineal society, so mine is a matrilineal society, so my role was very different. Couldn't be as active, or not active, but very voiceful like I am with the Navajo Nation. I had to kind of quiet it down a little bit and just really take time to observe. And I think that's one of the benefits for being Native, is like you just kind of sit back, kind of listen and learn, and just kind of let the community tell you what they need, versus the other way around, where you often just go in there with an agenda and then you come out with whatever product that you want. Well, that is not the case for the work that we've been doing among our communities in Rapid City as well as Navajo Nation. So up to this point, I had done, in early in my career, I had just mainly done secondary data analyses, kind of understanding better what was happening in Native communities. And that led to a colorectal project, which I had no idea what I was doing. And in that setting, actually, we were talking about just some of the factors that lead to increased colorectal cancer among the Lakota communities. And this woman says to me, "Dr. Henderson, I have a question for you. If you're saying that smoking leads to colorectal cancer, does this mean that when I do my prayers in the morning and I light up a cigarette and I put it down, and I'm smoking and I put it down, and the smoke that's coming off from my mouth and the cigarette is causing harm to my children?" And I had to look at her. She's like, "But I'm saying this, it's a prayer, that I'm giving, so it should be sacred, right? That the smoke should be harmless." And I had to look at her. I was like, "Gosh, that's a very tough question." But I said, anything that is not, that is commercially made, and we know all these harmful ingredients have been put into a product, if we know that already and we acknowledge that, then that product is still harmful regardless of the prayers that have been put into it. And she just kind of was puzzled by my response, and that led to this project that we did. She's like, "Well, I think we need to do a project with our community. I think it's just not me that is smoking in our homes, either through prayer or through casual use." So I was like, "Well, what would you like to do?" She's like, "Well, let's kind of come up with a strategy." So it took many months because this would be my first intervention project. And I said, "Well, I can't do, I could write the grant, but we're going to need a lot more people involved." She's like, "Well, I can get a group of people involved. I'll get the local leaders. I'll get a couple local leaders, as well as some of the folks that have done research in our communities." I was like, "All right." So we started doing this together. And these individuals include two primary Lakota women that have done so much work in their communities in terms of education. And I just want to acknowledge them today. It's Cordelia White Elk and Karen Red Star. They're just really incredible women that have really helped us out. And we designed this project, and it was funded through a Peace series, an NIH Peace series, which is a huge, huge grant. And we were one of, I believe, 7 research projects. And we've just been really grateful to get it funded. And what I'm presenting to you today has been approved by the Ogallala Sioux Tribe IRB, so they know that I'm giving this presentation today. So the Ogallala Sioux Tribe is located in South Dakota. Many of you probably know about Standing Rock. Standing Rock, because of what has happened over the last couple of years, Standing Rock is the tribe that is up north near it borders North Dakota and South Dakota. Well, I don't have a pointer here, but Ogallala is down in the southwestern part. It's the shaded community, red shaded community, and it's one of the largest reservations in America. They have over 40,000 tribal members, and one of the things that they pride themselves in is that they have established a second of, I believe, 33 tribal colleges in America, and that they are the first tribe in America to establish a chamber of commerce, which is very, very important. But unfortunately, because of many policies that were passed over the last couple hundred years in terms of colonization, the tribe themselves is one of the poorest, live in one of the poorest communities in America, according to the U.S. Census. That county in which the reservation is over the past, I think, 30, 40 years have been one of the poorest counties in America. And then because of colonization as well, you know, a quarter of the tribe only speak the language fluently, which is really, really important. I know that there's been a lot of work being done to increase fluency, though. As I've said in Oceania, when we do talk about commercial tobacco, it is very, very important that we distinguish commercial tobacco from ceremonial tobacco. There's a big difference. And among the Lakota people and many other Northern Plains tribes, they use a plant called chanshasha. It comes from the bark of a red willow, and it's only harvest only certain times of the year. I believe it's like early winter when the plant is harvested. And it was important for this study to make that distinguish because of the comment that was made by that woman when she was describing her prayer. The Lakota community have one of the highest rates of smoking in America, and also secondhand smoke exposure is very high. In one of our studies, where we did a cross-sectional study of the Lakota communities, we found that we asked a question, how many people smoke in your home? And we were specifically interested in the smokers of this study, and 91% of them said they had at least one, whether it was them or another person, 91% of them actually smoke in their home. This is compounded by 90% of high schoolers that are American Indians in South Dakota. By the time they get into high school, 91% of them, or 90% of them, have tried cigarettes. So age of initiation is very high in this community. That by the time they're adults, more than 50% of men and women have smoked, and of course this is related to high mortality and morbidity. Also interesting about this community is the topography of smoking, that they're considered light smokers. And finally, because Native tribes throughout the U.S. are sovereign nation, even though state laws have passed smoke-free, very comprehensive smoke-free policies, the Lakota tribe, the Oglala Sioux tribe, does not have a policy in place currently. So they're smoking allowed in many public places. I've been going to this community for many years, and the one gas station that I've been going to actually had allowed smoking, so you can go in there and buy, you know, a bag of chips or whatever. I shouldn't say chips, like an apple. And smoking was live, but somehow, I'm not sure who did it, but just back in November, the gas station went smoke-free, so we're really, really excited by that. So all of you know just the harmful effects of secondhand smoke exposure. It's a class 1A carcinogen. Exposure leads to all sorts of diseases that we're very, very familiar with. Also that there's actually, we found that there's carcinogenic compounds of urine, in urine of smokers, as well as non-smokers who have been exposed to secondhand smoke. So with this information, we began to collaborate, like I said earlier, with the community, and it took many meetings for them to really understand the importance of tobacco policy, particularly in homes. And And one of the concepts that have really emerged through this whole process, and for me as a non-Lakota woman, is Mitaku Ayasi, which is we are all related. You know, even in this room, we are all related, but there's just a special bond that occurs when an Indigenous person engages with another Indigenous person's. We quickly acknowledge that, and quickly relationships are established. So with these women that we were talking with, and men, there's a couple of men in this group, I became their sister, you know, and that relationship just really moved things a lot quicker. They knew that they could trust me to come into their communities and not just gather data, but to really have a huge impact, you know, with the results of this data. So one of the things that we wanted to do with this project was to intervene in smoke-free in homes, Lakota homes. And we know that the primary source of secondhand exposure for many families throughout the US and probably here are in homes as well as vehicles. And that there's really no laws, even if you pass a comprehensive law in your community, it does not address home unless you're in in public housing, like in the United States, that has gone smoke-free. And exposure to children cause many different things. We know this very well. It causes SIDS, to respiratory illnesses, all the way to learning disorders and disabilities. So as we were talking about an intervention, you know, and I had a colleague that had done a little bit of work in African-American communities. You know, we were chatting. She's like, I told her, I said, we have a community that's very, very interested in doing a smoke-free home intervention. I was like, do you have any ideas? And she's like, well, we did this project and we used biomarkers among the community members and found that it actually may have some potential impact. So we looked around, we did some research on our own and just kind of gathering data about what studies had been done, and found out that actually biofeedback was shown not to be as effective among smokers, and that there has been few studies that have used children's biofeedback markers. But at that point in time, though, there was no intervention of any sort in American Indian communities to address secondhand smoke exposure. With biofeedback, we know that we can measure cotinine. We can also measure NNAL, which are cancer biomarkers. And that also using nicotine dosimeters, which can be placed in homes, can measure air nicotine as well as secondhand smoke exposure. So we've developed the aims basically to adopt this intervention into Lakota homes. So up to this point, the community had no idea what biofeedback markers were. So it took a lot of education to the community, telling them that what we were going to do was we're going to go into their homes, gather urine from their child, and the person that we would be recruiting would be a smoker. So that was, you know, up to this point, this tribe had been engaged in a lot of research projects. So for us to go into homes, that was not a hurdle at all. So one of the first things we did for this community was to define what secondhand smoke is in Lakota, and words were, you know, kind of passed on between the group, trying to figure out how is the best way to describe secondhand smoke, because up to this point, this community had not really talked about it in a setting. So they came up with a few words. Oniyasika means bad air. That was one of the words that they came up with. And one of the ways that we wanted to really engage the community was the recruitment process. And they were so wonderful in providing us with recommendations on how to go about doing this project. And they also helped us in refining the project so that it's specific for the Lakota people. Included in part of the intervention was this flyer that, not a flyer, it's actually a comic book that we did for the kids. And we augmented that because it had been previously created for the Hispanic community, but we changed the image, we changed the wording and everything about it, and we hired a Lakota artist to do the drawings for us so that the kids, when they viewed the comic book and talked about secondhand smoke exposure, they could relate to it. For all of you that are doing work in research, there was, of course, the inclusion criteria, a whole laundry list of people that we wanted to be included in this project. And of course, age was important, as well as being head of household and being the decision maker of that household. And the critical part was we needed a child that was between the age of 2 and 8 years old, and we cut it off at 8 years old because beyond 8 years old, we know that experimentation with cigarette was probably beginning to occur, so we kind of limited our age limit, and that they had to live on the reservation, that they were living in the same home for more than 3 months, and that they were willing to have an American Indian researchers to come into their home. So they had the family members. That one particular person had to agree to this and currently had no smoking restrictions within their home. So that could mean partial, like maybe they allowed smoking in their restroom, or that was allowed. So any form of smoking in their home was allowed. And at the end of recruitment, we recruited 110 families, 56 in the active arm and 54 in the control arm, and we collected very detailed data, a very detailed survey from the individuals, as well as we put dosimeters in the homes both before the intervention started and at the end to measure the amount of nicotine that was in the air. For those that were in the intervention arm, the active arm, that's where we used the biomarkers. We gathered biomarkers from them, as well as cotinine levels and NNAL levels. So we know that for dosimeters, it's very, very sensitive for nicotine levels. It doesn't measure anything else other than nicotine levels. So if there was other forms of smoking that were being done in that home, that actually did not pick it up. So we made sure we told that to the family members in case other forms of smoking were occurring in that home. And then from previous studies, we know that a child with less than 2 nanograms of nicotine, that means that that child was not exposed to secondhand smoke exposure. But children between that were exposed, the range was between 20 and, so this is important as we discuss the data. So between 2 and 20, we know exposure has occurred. And for NNAL, anything less than 0.02 picomoles had significant exposure to secondhand smoke exposure. So this is where the role of academia came in. They were the ones that really helped us analyze the data. We had a couple of folks that were on board in terms of measuring the dosimeters, in terms of measuring the biomarkers. We sent everything out. We sourced it out because our nonprofit organization is really tiny and we can't do a lot of these technical things. And they were able to do all this stuff for us as we did our project. So the results this is where I get really excited because this is the first time we're showing this in American Indian communities. But just kind of a little bit of demographics that the median age is 34. The 81% of households that were participated in this project were women. And of course, like I said earlier, that high rates of poverty in this community. And that the number of people in their home, it ranges about 6 individuals. So as we kind of look at this information, at the end, unfortunately, nothing really panned out. It was non-significant in terms of looking at children's biomarkers, exposure, cotinine levels. Actually, this is at the initial part. So we're comparing the levels of nicotine as well as of NNAL. So what we did, let me go back. What we did was we gathered urine from both from the active arm as well as the baseline. So everybody got their measurement, but we didn't give back feedback to the family members unless they were in the active arm. So we got the urine and got it measured. When we got the information back, we went back, sat down with the family member and told them that their children, their children's measurement for cotinine as well as NNAL. So for the dosimeter, again, there was no change, unfortunately. That basically family members did not, despite us giving them information about cancer biomarkers, there was no change in in-home smoking. And again, for the cotinine, there was no change as well. However, they did say that that they verbally told us, yeah, we did make some change. So these are self-reports that they gave back to us. Like we did maybe make the living room smoke-free or the bedrooms of the children smoke-free. But this was a small pilot project that we did, and even though the results did not show a significant change, there was trends that were there. It did show us that that if we collected more people into the intervention, that there would be significant values to it. But unfortunately, that didn't happen. So hopefully, in our next project, that we will be able to do that. So in implementing such a study in a Native community, though, I think for me as an Indigenous researcher, that's the important thing, is like to engage with them and to let them know that even though there's been high exposure of nicotine and to these individuals, to family members, to these children, that they themselves can create change. I think one of the most significant part of this study was to show that this was actually the first time that high levels of carcinogens were found in children who had been exposed to secondhand smoke. High levels. And as we gave this information back to both the active arm as well as the control arm at the end of the study, there was actually like a lot of people that were in tears. They didn't realize that high exposure had occurred among their kids. So this led for us to think about how other ways can we work with this community. And one of the things that we decided to do is to give this work to give the findings back to the tribe. We have met several key leadership individuals during this time period, as well as we presented our work to other tribal communities in the U.S. And at this point in time, we're really excited to tell you that this tribe is exploring smoke-free policies. And I think they're wanting us to now calculate for them if they were to implement a smoke-free policy within their community, including their gas stations, and not the casino though, and that's one thing that they're wanting to kind of keep away from it. But I told them, it's like, you know, what I can do for you is do both. We'll let you know what kind of savings, medical savings, healthcare savings you'll have if your casino goes smoke-free. And this is a tribe that, of course, really depends on any source of economic development, and casino is one of them. And we also wanted to try to really impact policy more at a community level. So we presented to the Head Start program, the head of the Head Start program there on the reservation, and they were really thrilled because they told us that a lot of the kids that go into their program actually miss a lot of days at school. And they wanted to ask, or they asked a question, they asked a research question. It's like, what can you do? What can we do to decrease the number of exposure to our kids? So right now we're in a planning phase with them to develop a research project where we'll be providing the staff there with motivational interviewing. So they'll be the one that will be intervening with their with the guardians of the kids. So again, that's just in the initial stage of planning. But for me as an Indigenous researcher, I think this project actually led to me getting my first R01, the National Institutes of R01, which is like the creme of the creme, you know, when it comes to research. You're wanting that R01. I just got one last month, so I'm really, really excited to, for me as a researcher. And I think for Indigenous peoples, because like I said, we, as Native people, we're wanting to create change, and I believe that we have the answers within our own communities to create change. And I'll just end with this quote. I gave it before. I always say that with sovereignty comes responsibility, and it's the responsibility of the health of our people. I think it's really important that we create an environment where that our kids, our children, our seventh generation will be able to live in a smoke-free world. And I think it is possible. Even the rates, although it hovers around 40 to 50% in many communities, I think with a lot of effort between academia, tribal partners, research partners like our own, as well as tribal communities, it is doable. And I know that with the 2025 smoke-free initiative that is happening here in New Zealand, that you know, we've had a lot of conversation over the past couple of days on how this can be achieved in the Māori community. You know, and I always emphasize that there's the knowledge is there. We all know that, but it's just kind of accessing that knowledge, the Indigenous knowledge, I believe, is probably the key important thing that's going to make it happen for the Māori people. Is, you know, we cannot avoid that. We cannot say and dismiss it. For me, at least, as an Indigenous woman, I believe that using that is very powerful in our work. So with that, I'll end. I know I kind of went over time, so yeah, just want.
Thanks very much. So we've got some time for questions. Dallas?
Thank you. That was a really interesting talk. I was fascinated with some of the things you said. I spent a little bit of time in North America. So the two things that I think would be different between New Zealand and North America is one, the sacredness of tobacco as a herb amongst the First Nations people. And in fact, when I was in Ontario, the idea of smudging with tobacco became something that was beginning to become part of things in the white community as well as the First Nations communities. But the other thing was Indian cigarettes, and I'm pretty sure, but I don't know, is this true in the US as well as Canada, where because the reservation is a sovereign nation, the federal taxes on tobacco are not applied, and so people who are smokers can go down to the reservation and buy cheap cigarettes from the Indians. And I was wondering if those sorts of, one of the things we're doing here is looking at increasing the taxes on cigarettes and therefore increasing the price of cigarettes with the hope that that will decrease the amount of cigarettes smoked. And I was wondering if that kind of angle had been thought about at all amongst First Nations people on reservations.
Those are two great questions. Absolutely. The big difference for the Maori, between the Maori and the indigenous of North America, is the role of sacred tobacco, ceremonial tobacco. But I think, though, in the Maori people, from what I've gathered over the last couple of days, I think the concept of using plants for ceremonial purposes is there. I think what has happened on our end, and I forgot to mention this, is that we were banned from using any forms of ceremonies for over close to 100 years. So whether it was, we couldn't use the plants that we had used for ceremonies. So cigarettes just kind of came in. That was driven by the federal government and probably by the industry as well. So by the 1970s, many of our tribal ceremonies and cultural gatherings were using cigarettes. So I think if that had happened here, you might be dealing with the same issue, but it didn't. In terms of taxation, yep, the Navajo Nation, not just the Navajo Nation, but tribal nations are sovereign, so they make their own laws in terms of smoke-free laws as well as taxation laws on tobacco products. And the states have been really wonderful in working with the tribes and engaging with the tribes to form compacts so that taxes would occur on tobacco products, and many of the tribes, actually many of the states, are giving those funds back to the nation, which is really nice. And I know that on Navajo Nation, they've set up a commission to do that, to monitor those funds, and that those funds are focusedly for preschool kids and younger. So any initiative, it's the First Things First Fund, it's called, and so Navajo Nation is kind of getting into that. And what we've encouraged with our tribe, the Navajo Nation, is like, you know what, you don't need the state to tell you to increase your taxes. You can do it. So they did that. They increased it by 60 cents, and we're going to be working with them to increase it by another couple of dollars in the next month or in the next year or so. And I told them, and one of the questions that we're doing with the tribe is asking the question is like, where do you want this money to go? We can, up to this point, it's just been going into a general fund and kind of disappearing, right? We don't know where the funds go. It's like, so we can either earmark it for tobacco prevention, like in a state, in the tribal health department. We can earmark it for tribal communities, so the tribal communities can decide how they want to use it. There's 110 communities. Or we can earmark the funds so that the traditional healers can access that fund, and they can use it for educational purposes, like distinguishing between ceremonial tobacco versus commercial tobacco. I need to mention this. I, as a Navajo woman, because I am a woman, I cannot talk actually about ceremonial tobacco. So my role is very different when it comes to public health from the traditional side of it. That's the role of a man. So any Navajo man can come up here and talk a little bit more about that. But my role as an Indigenous woman, as a Navajo Indigenous woman, I can focus on prevention and just address commercial tobacco.
Was there a particular reason you focused on smoking in homes as the sort of as the intervention? Is that something that you identified as especially important?
Well, based on the cross-sectional study that we've done, we saw that there was high rates of exposure that was occurring in the homes. And up to that point, there was very little effort that had been done to educate people about secondhand smoke exposure within their homes. So I think that was probably the driving force. And just that woman telling the story that her child, that her grandchildren were exposed, I think that kind of led us down that road. This is something that needed to be done. And we just, so I gave this information and presented this work to one of the local, the neighboring tribe or related tribe. And they were like, you know what, let's do something. And this is a tribe that just recently passed a smoke-free, very comprehensive commercial tobacco-free policy. And they're like, our policy does not cover homes. So let's do this. So we developed a project with them, and in this project, we're going to actually not be working with a smoker, because in our study that showed, even though it's a pilot study, showed that there was really no effect. We're going to be working with non-smokers, a non-smoker head of household, educating them with advocacy skills, measuring their urine for cotinine as well as NNAL, and giving them back those information and really getting them up to par. Also, I think I forgot to mention my husband, based on this work too, also we know that advocacy skills are really needed at leadership level. And we developed a project and it got funded, where we're going to be giving advocacy skills to leadership members, anybody that is in leadership, and however you define leadership, or however the tribe defines leadership, whether it's a traditional healer, an elected leader, a school administrator. We're going to be giving those skills to those people, and hopefully at the end of this, and we'll be tracking policy changes at the end of the study. Hopefully we'll have a smoke-free community for this community. So I think it's really important, and I think advocacy skills are really up. It's kind of, we've taken it up a notch with Standing Rock, and it's been really exciting to see that. And I always say to individuals, like, oh yeah, it's Standing Rock, let's keep water sacred. I was like, well, just like we want to keep water sacred, we should keep air sacred. And they're like, oh yeah. So I think there's kind of a light bulb turn on at that point when you kind of switch it around for them.
Just one comment about when you said, even though there are differences in our historical relationship with tobacco, like Māori were tobacco free, there was no tobacco in New Zealand. I think the point that you're making is that and that the theme is the same, is that we want to reclaim what traditionally was ours and not accept another sort of product or way of living. So I think there's our journeys are similar with that part of our vision for a smoke-free 2025 here in New Zealand, reclaiming what we were once. And the other thing is, so it's my understanding that there are not many tribes that are working in the smoke-free area. And do you think what you're doing now will have a ripple effect with other tribes? Is there potential for it to grow, I guess, across America?
Absolutely. We have 566 federally recognized tribes, and probably less than 5% maybe have smoke-free policies in place. But I think it's been such a social norm. It's been so accepted. It was in our ceremonies. It was in our cultural gatherings, it meaning cigarettes, that we've just accepted. But I think with people like me, I have a role. I'm a mom, so I really, I'm very passionate about the work I do. If I see a Native child smoking, I will stop and tell them not to smoke, you know. And I think that whether they're a Lakota child or a Navajo child, I think that's the important role that I think reclaiming, you know, it's reclaiming our role as Indigenous people, and that, you know, we have to protect our kids. And I think once they understand, I know it's going to happen, once I think our Indigenous people understand that we can do this on our own. We may need a little bit of help, but I think our role is so, so important.
Time for one more question. George.
Thank you very much for the idea of biofeedback as a way, or biofeedback about the children's levels as a way to get smoke-free areas. Besides, or as well as that, do you have any ideas about community level interventions rather than individual level interventions that would develop smoke-free homes? I'm just wondering if biofeedback can be used at some sort of community level, or other interventions, or I mean, why I'm asking is that often it's much more, it's cheaper to do something at a community level rather than person by person, household by house.
Absolutely. I think creating change at a community level has a huge impact, and more powerful probably impact, because you're intervening at a higher level, and more people will be covered under that umbrella versus home to home. And right now, not the FDA, but HUD, the Housing Urban Development, actually passed a policy at the federal level to implement a smoke-free homes for individuals. The only people that were exempt from that agreement were American Indians and Alaska Native tribes. So we were exempt, so now it's kind of fall back on us to create that. So I've been in conversations with individuals that are actually advocates, tribal advocates under the HUD initiative, and asking them, it's like, how can we do this? How can we allow this policy that has, great policy that has been created for at the federal level, be trickled down to Native tribes? And what they told me was that when the agreement was being established, the tribes said, we can do this. It's our sovereign right to create these laws. So now it goes back to us as advocates, educating these leadership and kind of letting them know, it's like, yeah, you can do this. It's like, let's do it together. I can help. I can help you create this. And I think with this tribe, with the Oglala Sioux tribe, you know, where I'm going to help them actually draft the legislation, and then we're going to include public housing as a part of it, so that it's covered. I think they're ready. Their neighboring tribe has done it. They see the impact of secondhand smoke exposure, you know, high rates of cancer in this community. So I think they're ready. I believe it's taken like 15 years for them to get to this point, but I believe they're ready. And I think once they do it, and I think other neighboring tribes will begin to implement such policy. And I see that with the Cheyenne River Sioux tribe taking that lead. And I believe they're the only third nation to have established such policy that is very comprehensive, and that includes e-cigarettes, all the way down to any products that the industry will ever think of. That's included in their thing.
Thank you. So it just leaves me to thank Patricia. That's a wonderful talk, and I think introduced some really important issues. Some of them are familiar in a familiar in a sort of unfortunate way in the stories of colonization and disadvantage and high smoking prevalence and so on, which are very familiar to us here in New Zealand. But I think also coming out of the Oceania conference and the work that's been going on Indigenous tobacco control, I think all of us who attended the symposium at the Indigenous tobacco control symposium at the Oceania conference couldn't help but have been impressed by the degree of solidarity and collegiality and araha between the Indigenous tobacco control researchers there. Is really impressive and important, and I think this is one area that really needs to go forward, and let's hope that Indigenous tobacco control can lead the way. And I think also the focus on smoke-free homes I think really is a critical issue in many ways. One, it's a very difficult one to address, as you've found out, and I think lots of other people have found out as well in intervention studies. But the protection of children is so important, both from a sort of we like to protect our children, but I think from a social justice point of view, these are a vulnerable, involuntary, exposed population. They deserve our protection, and that should be one of our priorities in tobacco control, as well as stopping smoking or preventing smoking and helping smokers to quit, but also protecting people from secondhand smoke, and particularly vulnerable populations like children. So I think, and the other thing we found, I'm not sure whether you found it in your communities, is smoking in the home is a major risk factor for starting to smoke. It's a really important exposure, and work that Jude Ball, who's in the audience here, has been doing. Anna and I have done a bit in the past as well. This has come up again and again as it's potentially a modifiable risk factor for children taking up smoking, at least here. So that's yet another reason to address it. So thank you very much. As I said, I do think the Indigenous tobacco control is really important. Out of Oceania, there was an Indigenous declaration of tobacco control, which was another important development there. So thank you to you, Patricia, and also to Jeffrey, of course, for your contribution and your wonderful talk today.